Today the title of the talk is Echo Conundrums. It's one of my sort of favorite topics. The expanded version is Conundrums and Decums. So all right. So these are the objectives. So we're going to review echo images. Sometimes they're going to be sort of short snapshots to get people to kind of think about what they're seeing and what it could be and how would they go about further delineating what structure, what abnormal flow we're seeing. But sometimes they'll be kind of more comprehensive cases. I think I should have enough to fill a good 15 minutes or so. And then discuss, and you'll see us implement some approaches to determine the underlying abnormalities that we're seeing. So hopefully get some input from either the online audience, and you can put stuff in the chat, we'll try and monitor things, or the folks in the room, which are mainly the sonographers. And some of them are, like I said, some of them are like 1 or 2 images, kind of snapshots. And somebody recognized
Echo Jeopardy.
Sorta. I thought about putting it into a bit of a game show format, but it doesn't make sense. The problem is that a lot of times to really move fast, you have to do multiple choice, and sometimes when you put the answer is obvious once you see it, but it's not obvious if you don't see it. Okay. So what do we see here? So what view is this? Yeah, this is the RV focus view. Okay, so, and what's the unusual abnormality that we're looking at that's kind of strikes your eye?
About the, let's say, color on the RV.
Yeah, so there's an unusual color flow here.
Yeah.
That is unexplained, at least unexplained on this view. So what could this be? So if the sonographer is scanning and they're seeing this, what are they thinking? What's the possibilities?
There's some obstruction.
Pardon me?
Some obstruction.
Obstruction where?
Mid RV.
Okay, so mid RV obstruction, kind of similar to how we get mid LV cavity obstruction in hyperdynamic LVs. Okay, that's possible. Pardon me?
VSD?
Yeah, well, so why do you think VSD are?
Well, it's away from the transducer's blue jet. And
Yep.
I can't see the sensitivity actually, but that's like a common MGMI structure of the apex.
Yeah, so that's a good thought actually. So it's blue, so we know it's headed towards the tricuspid valve. So it looks like it's coming from somewhere originating in the mid RV, and it's headed superiorly towards the ambulance. And if you look at the timing, it's predominantly systolic, right? And you can tell because it occurs when the tricuspid valve is closed and the RV is contracting. And of course, we have the ability to slow it down and look at it in relation to the QRS complex. But as I tell the fellows that the experienced sonographer and reader doesn't have to freeze and scroll, but the more novice readers will have to freeze and scroll. And it's particularly more challenging when the patient's tachycardic, of course, because the cardiac cycle is short. So could this be a
muscle bundle?
Yeah, there's a bit of muscle bundle as well. So I think that was kind of what Grace was thinking about, with maybe a muscle bundle obstruction at the mid RV level. We've seen that kind of rarely. I think this is one of the things that was on the differential for this case. I've shown this case before in more comprehensive versions in previous rounds. What are some of the other abnormal flows that we can see in the right ventricle that this is probably not? What are the fistula that we see in the right ventricle? Most commonly, fistulas. What are some vascular structures that can empty into the RV abnormally? Priya.
An anomalous into the RV?
Yeah. Or it's any cardiac chamber, but yeah.
I was gonna say an anomalous like SVC. But that would be more RA, not
Yeah, yeah, exactly. Like a left SVC.
Yeah. But not weird. No. Oh,
They're usual for a venous structure, but yeah. What else? Come on. What are vascular structures around the heart? Give me some vascular structures around the heart.
PA.
Okay.
Coronary sinus. Coronary sinus.
Huh?
Coronary sinus.
Well, coronary sinus is at the base. Okay. So what feeds blood into the heart? What supplies blood to the heart to allow it to pump? What do we call those suckers?
Iris. Coronary.
Coronary arteries. Oh my gosh. You know this, right? We see coronary fistula into all the chambers. So could this be a coronary fistula into the right ventricle? I wake you guys up here, right?
Coffee's late.
So could this be? What's against it? Yeah, so the timing is against it, right? So the timing is predominantly is more diastolic than systolic. You have fluid in the coronaries doing systole and diastole, but it's predominantly diastolic. And this is mostly systolic. Anyways, this is supposed to see a warm up. You guys think so this is a VSD. So this is a muscular VSD that now you see the origin, of course, but we saw the tail end of the flow in that arc. So it's a nice with the muscle on the next side. So okay, all right, we gotta warm up some more. Okay. All right, so it's a muscular VSD with left to right flow. So
Was it your case?
so
Yeah,
think
it's the croissant.
so think timing, velocity, direction when it comes to flow, right? And then think adjacent structures. Right? That's good. All right. Next case number 2. So apical 2 on the left, apical 3 on the right, something in the left atrium. What is it?
Looks like an aneurysm interatrial.
Yeah, so this is an atrial septal aneurysm. We're just seeing it off axis on these views. And then this is quite mobile, back and forth.
Oh.
Thank you, Amin. Great. Okay. This is something that you see and you know exactly what it is. Sonographers know this. Apical 4-chamber view.
Looks like an extra cardiac mass of compressing the RV.
Yeah, there's something compressed in the RV. Okay, it doesn't have to be mass. What's the
Hernia.
Okay, so, but the hernias are generally on the inferior part, right? So now you guys know this because you're scanning and you can tell. You don't have to. You don't because the patient's in front of you, so you know this particular abnormality that can be associated with other cardiac abnormalities. Yeah. So what's that called?
I just lost it.
Pectus excavata. Yes. So this is a patient with pectus, right? So this is quite common, right? Looks like it's compressed in the RV. You just have to see it once and you know it's pectus. And they're difficult. They're really challenging patients because the septum is now pressed up against the RV. Remember, the RV is the most anterior structure in the anatomically normal heart. Some cases a little bit longer. Okay. There's a cyst in the right atrium.
Yes.
Yes?
And
No.
no.
So what is this?
It's spicy.
Huh? I guess it could be. What kind of device could it be? It could be. But what kind of device are you thinking? Okay, so ASD closure device. All right, yeah, that's kind of related a little bit because on this view, the atrial septum is sort of en face. Anyways, this is this. What's this? This is another atrial septal aneurysm, except now there's a consistent bulge from the left to the right. We're just catching it off axis. So this is a very large atrial septal aneurysm. So we'll see that occasionally on the first view of it is in the RV inflow view. So it's just en face. So with the RV inflow view, you're cutting it essentially through here. And all you're seeing is this round portion coming up here. Okay? How do I find these? So I have like a folder. So I'll be reading studies. I'm going, oh my gosh, what is that? That's really deep. So I just save it. I just don't think I see it. So.
Thank you.
Howard?
Yeah.
Sorry, excuse me. Can I ask a question?
Sure.
When we deal with atrial septal aneurysm or like mobile atrial septum, do we automatically do bubble study?
I think sometimes we do, but I don't think we necessarily have to, unless it's a question being asked. But I don't think we. It's not part of our protocol as far as I
Okay,
know.
so we have to just check with you every time.
Yeah, it's always
Yeah.
useful to check with the reader. You're right. Readers might have different preferences. Obviously, there's a common association with atrial septal aneurysms and PFOs, right? So now whether we be screening for PFOs on all patients with, I'm not sure if that's yes. I personally wouldn't. I as a cardiologist, that information would not be particularly useful for me. So might be a bit stressful for the patient. Okay. All right. So this is a DEFINITY study done.
Side by side. Right and left, yes.
I like Grace is thinking way outside the box. Like way outside.
Both arms.
What do you think?
ASD.
Pardon me? ASD. Yeah, so
The right side is.
yeah, so this is DEFINITY, but it shouldn't cross into the left heart this fast. And at the very beginning, you'll notice that it probably crosses the atrial septum.
They can see.
Very, very quickly.
So this is still not an absolute contraindication.
This wasn't known at the time of the PFOs aren't. PFOs are not a contraindication. ASDs by themselves are not an absolute. And I always tell the sonographers if the patient has a large right to left shunt, particularly in the presence of pulmonary hypertension, I probably wouldn't use DEFINITY contrast. I don't think it's been well studied. Yeah. And actually, the flip side is that with a large shunt with severe pulmonary hypertension, like an Eisenmenger ASD, for example, is probably a relative contraindication even for saline contrast, because you can still have symptoms with even actually saline contrast injections in these patients. All right, so this is not DEFINITY. This is a regular good old saline contrast microbubbles.
Same case?
Yeah.
Yeah.
So it's kind of funny. I think this was, I'm not sure if it was done after before. It might have been done after actually. So and then if for extra bonus points, what's the underlying diagnosis other than the intra-atrial shunt, which is probably a PFO in this circumstance. But I know why you said ASD. Why did you say ASD?
It's very large. It's right away. It's very early.
Yeah, but there's another
The
reason why you.
RV
Yeah, exactly. So the RV is dilated. Okay. All right. So this is one for Dr. Chow, because Dr. Chow is here. You'll notice the abnormality and the contractility of the right ventricle. You see better on the contrast there. Yeah. So yes, yeah. This is a patient with a very large pulmonary embolism, dilated right heart, and then increased right-sided pressures, then shunting from right to left through the PFO. Okay, conundrum. Keep pulmonary embolus with PFO and right to left shunting. Yes.
Have a plus or 3 plus or bubble study. So actually,
No. Oh, well, I shouldn't say that. Depends on the timing.
So timing would.
Because you can get a 4+ shunt from transpulmonary.
Yeah.
Now, sometimes you'll see it streaming from the pulmonary veins. It's pretty clear, but the timing helps a little bit with regards to intra-atrial versus transpulmonary shunting. So a really good Valsalva, it should really increase with Valsalva release. But if it's 4+,
it's gonna be 4+.
it may not be increased that much. So, but as
It's severe.
yeah, it's unlikely that you'll need a Valsalva if it's 4+. But I reserve the right to case by case basis make a decision. All right. What the heck is that?
For the coronary sinus.
Coronary sinus is in the differential. Huge.
It's huge.
So the only issue, so if there's a reason why it's probably not coronary sinus. What's the reason why it's probably not? So where's the coronary sinus?
Right,
So it's in the AV group,
Yeah.
right? So this looks anatomically like it's extracardiac. So the AV group is the kind of here, and sometimes when the coronary sinus dilates, it comes up over here. Like this.
Coronary sinus is intrapericardial, would be moving with the heart. This is not moving with the heart, it's extracardiac.
Yeah, so we agree. Yeah, this is extracardiac. And if it's extracardiac, what is it? Yeah, so that the differential would be the descending thoracic aorta. And the way to help prove it sometimes you can get more long axis views. So what are some of the so here there's more of a short axis view of the descending thoracic aorta. Remember the descending thoracic aorta marks whether or not this is more likely a pleural versus a pericardial effusion. This looks more likely a pleural effusion. So what are some of the views where we try and see the descending thoracic aorta in long axis? Two-chamber view is pretty common. And another one? Short axis, right? So and here with 3D probes now, you could just use the 3D probe and use X-ray imaging to see the long axis. And then to help prove that's in descending thoracic aorta, once you see that tube, then you use things like color and spectral Doppler to look at flow. So there's another way to look at flow. What's the other way to look at flow?
First pass affinity.
Contrast.
You knew it was coming.
So nice example. And actually, this was done in part to look for dissection. Pretty large descending thoracic aortic aneurysm. Unusual, right? We don't normally see it this large. And we actually don't have a good. Actually, I can't remember whether or not the ascending aorta was also dilated. Okay, how are we doing? 825. Okay. All right. What about this? The heck is that? Kind of same location.
It's like a device in the descending thoracic aorta.
Yeah, so it's some kind of device for sure. It looks foreign.
Yeah.
Looks and actually, why do you say it's a stent?
Because
It's a zoom.
because you look at it's kind of the rings. See kind of
Yeah, it looks pretty
around,
circular, and then there's
and
these little dots.
that's what I was trying to say.
Yeah,
Yeah.
it looks like the mesh of a stent, right? And you're right. This is a stent. What kind of stent is it? Pardon me? It could be a TVAR. I don't think. Well, EVAR is usually that's in the abdomen. This is up in the thoracic cavity, right? So that's why the T in TVAR is thoracic in the vascular aortic arrhythmia.
In the deep, is it anterior to the descending aorta?
Yeah, so is that the aorta here?
Yeah.
And if that's the aorta, what's the structure between the aorta and the left atrium?
Person I will be in there later today.
What's the structure between the aorta and the left atrium that we put probes down? Yeah, this is the esophageal stent.
Oh.
Yeah, this is a patient with metastatic gastric cancer who had a stent put in for obstruction. So it means it has a hiatus hernia. It's in the differential when you see an echo-free space because the hiatus hernia is essentially an extension of the stomach up into where the esophagus should be. So the still end. Sometimes we'll see echo-free spaces here where it's possible that it's a hiatus hernia. This is kind of a variant of that. This is an esophageal stent. Only one I have in my collection. And yeah, we tried to do color Doppler. Obviously, there's no flow. So, if you wanted to delineate this, what would you do?
Contrast.
Contrast, yeah, but different type of what kind of contrast are we talking? Huh?
So
A carbonated beverage.
right.
Right?
True.
What was the last time? So who here has given a carbonated beverage to a patient while scanning?
I watched one.
Lindsay, like,
I've done it before.
yeah, I'm not here.
No? It's like an old school trick, right? So you keep a can of Sprite in the fridge.
Oh, yeah.
That's the options. Okay, so how you guys did? Did okay? All right. Okay, so sorry, question? Was your question? Okay. All right. What's the abnormality? I guess what's the main thing I'm wondering about here? Yeah, so you're talking about this structure here, right? So is that the PA? It's a common place where the PA should be, right? Okay. That's from previous structures here. Descending thoracic aorta over here. I suspect that's coronary sinus here. Okay, and then mitral calcification. But there's something here. This is where the PA should be. But there's something inside it, right? So the
Mobile.
So mass aortic clot. Okay, that's possible. Yeah. So what's this?
It's like,
It's a space wire. Yeah. So, and then so the question was, has the pacer wire migrated into the RPA?
Oh.
There's a bifurcation. See it there.
oh,
Like it. So it's a sweep. So what are we seeing here?
it's the tip.
SVC? Yeah, so pacer wire in the SVC. So just anatomic.
There we go.
So it's the wire in the SVC that we're seeing. It's an unusual location, but I guess things are kind of distorted. Patient has severe
Did that.
agitation.
What's the next
Yeah, that picture.
Yeah.
Yeah, so using
So that-
X-plane, using sweeps, off-axis views, right? That's how we hunt things down, right? Yes. Okay. More abnormalities outside the heart. Echo-free space, some structure within that echo-free space. It's like a tube, right?
Not that they're like a draining tube.
Yeah. Drain tube into what? It could be pericardial.
Yeah.
Could be pleural.
Yeah.
I'd probably guess more likely plural. It's not plural. So here's a couple of short axes. This is way off at the apex, so you can see that. So that's the left ventricle over here. That's at the apex. There's a bit of off-axis view here just to see the tube here. And contrast does not opacify this structure, so it's not vascular, or at least doesn't have a vascular connection. So that's an NG tube. So chest X-ray, CT. It's a very distended stomach, kind of pushing up. So I don't think on the CT scan it wasn't above the diaphragm. So we just saw it quite prominently on the pastoral lung axis. Wow. Oh, this one. Okay. Right. Yeah. So there's a couple of echo-free spaces posterior to the heart, whereas my point. One here. This one has color in it. So what's the structure? So that's the descending thoracic aorta. So apical 4 zoomed, apical 2 So this is the carbonated beverage. This is the fizzy. This is the fizzy pop. So it's a dilated esophagus. And there's some echo density within it that we thought was retained food. Probably not the best example of a carbonated beverage scan, but I think you can see that it does opacify. So. Okay, just so trick up your sleeve just in case you want to show something is connected to the GI tract. So I was wondering yesterday whether you have the patient drink definitively, whether
Yeah,
I don't think that's ever been tried. I don't think we should try it.
What would be the dilution?
Yeah, I think you have to dilute for sure. I don't know. Oh my God. Don't give anybody any ideas. Okay, that's definitely us. That's definitely not our skills used for ourselves. Okay, all right. So a couple of short ones, then we'll get into one long case near the end. Okay, so there's tricuspid regurgitation is RV flow view. There's a normal flow here in the right atrium. Kind of going in this direction into the, here is probably close to where the IVC is. You don't see the CS. So, timing? Yeah, so what's this in the asking, right? So what flow is this? Yeah, so it's a flow across the atrial septum. So, this is a patient had a transcatheter procedure, so this is a hydrogen one. And you can tell from the flow, the left atrial pressure is probably quite high. Left atrium is dilated. That's why it's so prominent. Okay. All right, this one's a good one. This is a long case. We'll close up with that. There's a couple of really short, just interesting images at the very end. Okay. RV inflow view. What is that?
It's like an ASD closure device.
It's in the differential. We'll see better on the short axis. So you'll never guess what this is. Not on this view, you can't. It's like number 20 on the differential. So this is why we do cross-sectional imaging. Or you can do sweep, sure. We love our sweeps here. Some stenographers more than others, Aaron.
Sweet flag.
That's not a good idea.
Okay. Yeah. So means about it. So. So it's kind of close to where the septum is, but it's a little bit higher, right? It's a little bit, yeah. So what is this? Yeah. So this is a valsalva aneurysm, but there's more. There's always more. Tricuspid.
Yes.
So color Doppler. So what are we seeing here? Is there flow through the aneurysm?
Nothing that like more those like towards our.
So what flow are we seeing? There's a couple of flows. There's two different flows we're seeing. Yeah, so it's the aortic regurgitation. It's kind of eccentric, kind of comes down. What's the other abnormal flow? Sorry?
It's like
Remember it's VST.
Yeah, so it's a VSD. Yeah. So how can we tell this is obviously this is not, we look at VSDs here, but we also look at VSDs in abuse. But what are some of the clues that this is a VSD as opposed to a rupture of the sinus of valsalva aneurysm?
It's only systolic.
Yeah, it's anomaly systolic. Obviously, you want to use spectral Doppler to confirm that. And I guess location as well. So timing and location. What about this? Does that change your mind about VSD? It's kind of competing with concomitant tricuspid regurgitation. You can see the flow convergence, as to Mike's point, is kind of up here. So, although it's right where the septal leaflet attaches, right?
Yeah.
Yeah, so the differential, at least on this view, without getting other ancillary imaging, is a Graboni defect, which is a LVOT into or LV into RE. But the timing for that usually is more continuous because of the pressure differences. So of course, I mean, this is where you nail it on other views, right? So this is a long axis view. So this shows the membranous VSD, right? You see it's actually below or the LVOT side of the aortic cusps. And then of course the other view is one of the apical views. And you see the timing is mostly, so here's systolic, there's a little bit of diastolic flow, but it's systolic, high velocity between the LV and the RV, so pretty typical restrictive membranous VSD flow. And of course, the apical views, if you can get it, so you can see here, it's on the ventricular side, right? So kind of. So this is in 2012, and let me go back to the look at it. So that's the aneurysm, the signs of valsalva in 2012. So we fast forward a little bit to 2015, early 2015. So here's that same RV inflow view, a bit more prominent.
Almost looks as though it's a little bigger and maybe filled in, or it's, I don't know, something. If
Yeah, it's not as echo.
there's no lumen.
Yeah,
right?
there's no echo-free space that we saw before, and you can see that on the.
That Eamon said, is it clotted?
Yeah, so the question is whether or not it's thrombosed off. The other differential will be something else filling it, such as infection, vegetation. And flow? Any flow through it? No, it looks pretty similar. You have the competing tricuspid regurgitation. It's late 2015. So you can see the echogenicity is gone. Maybe a little bit of residual over here.
Yeah.
So the flow's changed. So she presented in heart failure. So this is a ruptured sinus of valsalva aneurysm into the right atrium. See right atrium spilling into the right ventricle. So it's created volume overload. Lots of color. And here the pattern has changed. Now it's continuous, right? This is one of the common causes of a continuous murmur. Here's a T. I love this T. And you told me you never saw ruptured sinus of valsalva aneurysm. So now you see one. So we've seen a few over time. So you see it's protruding into the right atrium, this very prominent continuous flow from the aortic root into the right atrium, spilling into the right ventricle. And she underwent surgical repair. Both the VSD and the ruptured sinus of valsalva aneurysm. Oh, it's nice, yeah. So you can see the color flow just fills that cavity, right? Okay. So sinus valsalva aneurysm, membranous VSD, then rupture of the sinus valsalva unit. Oh, right.
Robert, can you go back to that 2012 personnel?
Sure.
Forward?
Yeah.
All that feature and then break.
So, I guess it could be. I don't think there's any flow obstruction, but it could be part of the structure of the membranous VSD. When I saw this, I was like, "What the heck is that?" So what's the unusual thing about this particular image? What is this? Well, okay, so you probably know this case. But you're looking at this, right?
Yeah.
Okay, so we'll come to that later, but that's not the abnormality I'm looking at.
The leaflets.
Yeah, what's up with the leaflets?
yeah. They're like parallel.
It's like
It looks like
towards the left.
it looks like it's opening in the opposite direction.
Yeah.
See that? You see what?
I was thinking it's the aorta because it's opening that way.
Exactly. I was like, what the heck? Did they put the valve in on the wrong side? That'd be catastrophic. I don't think they should come off of that. But
Oh,
you see it?
inverted.
It's like can I see it? It's like an optical illusion.
Right.
It looks like the tips are opening into the left atrium as opposed to the left. Did you see that?
First time.
But I thought I was like, oh my gosh, look at that.
Surgeon,
Mike's trying to wrap his head around it, right?
at least they open the right timing.
I hope.
So it was going for the exactly. Anyway, it's just an optical. It's a bit of an optical illusion. The other issue that the leaflets are actually opening into the. It's just fine. So this is a valve in valve sapien, and then on top of that, because of paravalvular regurgitation, the patient had a plug. So that's a that's a plug for paravalvular.
Wow.
Looks like a panus.
So like Amin says, inverted MVR, which first of all, if it was an inverted MVR, the patient wouldn't be surviving to get a transthoracic echo. That would not happen. But it certainly looks like it. But it's an optical illusion.
But what if it was inserted transapically?
Oh no, what I'm saying is that the patient wouldn't have, if it was inverted, then the patient wouldn't have been able to survive to this end, because the valve wouldn't be able to open. Right? Yeah, the valve is not made to. It wouldn't be possible. Yeah. The other view, this is a bit of an optical. It's a kind of a neat optical illusion, actually. So I think part of it is that the valve in valve is a little bit more atrial, so you don't necessarily see the base of the leaflets on it.
Yeah, they're shallow.
Yeah. So it is weird, but it creates a bit of angst when you look at it. Okay, and then this one I like because this is kind of a fun.
You go first, I go next.
So actually, we see this.
Polite.
We see this. We actually, if you pay attention, we actually see this often. But what type of valve do we normally see this differential opening / closure of a mitral valve? It's more commonly seen with what type of valves? Mechanical valves, right? The bileaflet occluders, right? So you just see I have a whole bunch of collections where they dance, they go like this. But I've never seen it with a bioprosthetic valve. This is kind of weird.
Dance.
It's like, what? Probably has to do with filling of the ventricle in diastole. It's kind of cool. It's mesmerizing, eh?
It's a dance.
Okay, all right. So let's some take-home messages. So when you see funny things, consider anatomy. What are the adjacent structures and the physiology and flow? Look at timing, the direction of the flow, timing, systole, diastole, continuous. Velocity, high velocity, low velocity, in terms of where flow is coming from and where flow is going into. Use simultaneous 2D color Doppler, so color compare or simultaneous imaging. Sweeps and off-axis views. If you go off-axis, sometimes you have to provide labels for the interpreting reader if they're not quite in tune with what you're doing. But I could figure it out. I know you guys well enough, I could figure it out. And then use of the 3D transthoracic probe and expert imaging. I think we're doing more and more of that as well. We're bringing that into our armamentarium when we're not sure about structures that we can't get an idea. For echo-free spaces that you're not sure about connections, think about either if you think there's a possible venous connection or a connection to the right heart, then anterior contrast is really great. So structures in the RA, for example, ectopic spaces, and then ultra-enhancing agents, if you think it has any vascular connection, whether it's venous or arterial, because obviously the microbubbles go everywhere, blood goes. And Mike mentioned before, if you want to know about connections, then think about first pass. So think about starting the imaging before you inject, and then take a long loop, and then see what opacifies, and then timing of your opacification. Ideally, you want to see connection from one space to the other, but sometimes you're not able to. But you can infer some of that with timing of the opacification of that ectopic space, and then confirmation of whether that space is connected to the vascular space or not. A classic example is the pericardial effusion. That's you're not sure if it's related to a connection either from the RV or the LV or the right atrium, for example. We see pacer leads go through the RV apex with leaks that we've detected. And then if you're not sure, then you can repeat it. The only issue is then you can repeat saline contrast. It's pretty easy. Repeating the microbubble contrast is a little bit more challenging because it tends to last a little bit longer. You're gonna have to wait a little bit or destroy bubbles to do that. And then use of other imaging modalities. For example, I wouldn't be able to tell that was a esophageal stent unless I looked at the history. You can make some inferences, but
Now you can.
leave that correlation. Okay, all right, well, thank you very much.